Good afternoon. I'm Professor Shane Dark, and welcome to the final weekly NDART webinar of 2022, broadcast live as always from the ballrooms of Mars, which is, was and always will be the spiritual home of the great one, David Bowie. Now, while we are widely dispersed, we acknowledge traditional owners of country throughout Australia, recognise their continuing connection to land, waters and culture. We pay our respects to their elders past, present and emerging. I'm really delighted to be able to present our speaker today, Bernadett Tildy. Bernadett's a PhD student with the Nicotine Research Group in the Addictions Department of King's College in London. So department's had long and strong associations with NDARC and other Australian researchers going back to the 1980s. Her research investigates how smoking cessation treatment provision could be improved to address how countries can reach the tobacco endgame goal. Now, we spoke in an early webinar with Professor Coral Gartner about this topic of tobacco endgames and what this can plausibly mean, and the distinction between smoking and nicotine use in looking at such endgames. This webinar will explore provision of smoking cessation treatments, including e-cigarettes, in the context of primary care and the people who have serious mental health conditions, which is a group with very high rates of smoking. Bernadett will provide an overview of investigations into how smoking cessation treatment could be improved and the roles prescription e-cigarettes may play to further reduce the prevalence of smoking. And it's a real privilege to be also joined in Q&A by Professor Hayden McRobbie, professor with us at NDARC, but also consultant in lifestyle medicine at Lakes District Health Board in New Zealand. He'll be speaking to us from New Zealand. And he's taken time out of his very busy schedule to be with us today, and it's much appreciated. Hayden's one of the world's leading authorities on smoking and nicotine, and I'm just delighted he could join us today. You can ask your questions on the Q&A function. Please not on chat, on Q&A. I'll present them to the panel at the end of the presentation. I may not be able to ask all of them, but I most certainly will endeavour to do so. So with no more from me, now Bernadett, it's over to you.
Hi, can you hear me okay? Yep, okay. Hi, thanks Shane and everyone else. Thank you for inviting me to speak. So my presentation is called Reaching Smoke-Free. How can we improve the provision of smoking cessation treatment? And as Shane said, I'm a PhD student from London, and my PhD supervisors are Dr. Leonie Brose and Professor Anne McNeil. So firstly, I'm going to give a quick background about the UK smoking and vaping context before I talk about my PhD studies. So globally, you should know that cigarette smoking is still the largest single risk factor for death and years of life lived in ill health. In England, smoking is a leading cause of health inequalities, and is the second most important risk factor for death and disability-adjusted life years. Smoking prevalence in England in 2022 was around 13 to 14%, depending on which national survey you look at. And this graph shows smoking prevalence from the Smoking Toolkit study led by UCL. As you can see, smoking prevalence has generally been on the decline, but in most countries globally, there are variations in smoking prevalence by socio-demographic characteristics such as age, gender, socioeconomic status, and ethnicity. And there are some disadvantaged subpopulations in society which have significantly higher rates of smoking, as Shane mentioned. So as an example, smoking prevalence is a lot higher in people who are from lower socioeconomic groups and those who have mental health conditions. So for example, in 2020, smoking prevalence in low socioeconomic group adults in England was 21.4% compared to 8.5% in higher socioeconomic group adults. And in 2014, smoking prevalence in England was 34.1% in people with a common mental health condition and 19.6% in people without. So several studies over the years have found that people with mental health conditions are more likely to smoke heavily, and more likely to be highly dependent on cigarettes. So similar to the tobacco endgame in Australia, we have a smoke-free ambition in England, and it's called Smoke-Free 2030. So in 2019, the government set an objective for England to be smoke-free by 2030, meaning that only 5% of the adult population would smoke by then. However, modelling has shown that without further action, England is going to miss this smoke-free 2030 target by at least 7 years, and the poorest areas in society will not meet it until 2044. So here's an example of how we're missing this target. So some recent modeling has shown that assuming there's no change in the current annual decrease in smoking prevalence, people without mental health conditions will reach the 5% prevalence target in 2039, and people with mental health conditions will reach the 5% only in the year 2054. So the Tobacco Control Plan for England is the government's strategy to reduce smoking. And we were expecting the new Tobacco Control Plan for England to be released by the government a few months ago, but you might have seen in the news that there are political barriers ongoing currently. So the UK government recently commissioned an independent review, and this was conducted by Javed Khan, OBE. So the Khan review, called Making Smoking Obsolete, was published on 9th of June this year. This review sets out recommendations on how the government's ambition to reduce the national smoking rate to less than 5% by 2030 can be achieved. The recommendations from this review are supposed to be informing the new Tobacco Control Plan for England. So the Khan review set out 15 recommendations. And yeah, sorry, this is a busy slide, but I just wanted to highlight the 4 main areas of the recommendations. So part 1, the top left, basically is calling for more funding in general into interventions which can help achieve the smoke-free target. Part 2, the top right, is around prevention, and it includes recommending policies such as the one where you raise the age of sale of tobacco by 1 year every year, like the policy in New Zealand. Part 3, the bottom left, focuses on helping people who currently smoke cigarettes to quit smoking, and switching from smoking to vaping is recommended as a substitute. And part 4, the bottom left, is called system change. This gives recommendations about how existing systems, such as the National Health Service, should be used, and promotes the idea that healthcare professionals should use every teachable moment to deliver very brief advice on quitting, and this should form part of a revised core training curriculum. Also, it recommends that the NHS should incentivize its services to implement the clinical guidelines on stopping smoking, and also recommends that all hospitals should integrate opt-out smoking cessation interventions into routine care, and that messaging around stopping smoking in the NHS should be ramped up. And just to pull out a couple more, so recommendation 13 includes a focus on people who smoke and have mental health conditions. And recommendation 15 calls for an improvement in using research and data to monitor and evaluate the new approaches that this review is calling for, so that you can measure the effectiveness and cost effectiveness of interventions. So I wanted to highlight recommendation 8, as this is one of the areas of policy which differs a lot from Australian policy. Here, the Khan review recognized that vaping is important to reach smoke-free 2030 targets alongside other cessation interventions. The reason why vaping is recommended is because there is evidence which has shown that switching to vaping is effective in helping people who currently smoke cigarettes to stop smoking. So the update to the e-cigarettes for smoking cessation Cochrane review was published last week. And this review tries to establish if e-cigarettes can help people to stop smoking and compares its effectiveness against other cessation aids. And this newest version of the Cochrane review shows that e-cigarettes work better than nicotine replacement therapy and probably better than e-cigarettes without nicotine. So given all this, how do clinical guidelines in England currently regard e-cigarettes? So in the UK, e-cigarettes are licensed as a consumer product rather than being medicinally licensed products. Despite this, there was an update in November 2021 to the National Clinical Guidelines. The guidelines now recommend that health professionals offer nicotine-containing e-cigarettes to people who smoke as a cessation support option. And the following few slides are screenshots from the guidelines, so you can see. So the new guideline recommends that everyone who provides stop smoking interventions ensures that people who smoke are given access to nicotine-containing e-cigarettes as a cessation aid, alongside behavioral support and medicinally licensed interventions, such as bupropion, NRT, and varenicline. And the guideline also recommends that evidence-based information is provided. For example, that most smoking-related health problems are not caused by nicotine. The guideline acknowledges the evidence base which supports the notion that nicotine-containing e-cigarettes can increase the likelihood of smoking cessation. And the guideline links to further accurate evidence-based information about e-cigarettes. It also explains that e-cigarettes are not licensed as medicines, and that there is not enough evidence to know about any long-term harms, but the evidence is showing that vaping is likely to be substantially less harmful than smoking, and that the main goal is the cessation of combustible tobacco smoking. The guideline also recommends that it's discussed with the client how long they intend to be vaping, and advice can be given about stopping vaping. It recommends reporting any perceived side effects from vaping on the National Yellow Card scheme. And the guideline emphasizes that in order to overcome nicotine withdrawal symptoms, the concentration of nicotine delivered by the e-cigarette needs to be sufficiently high. So a quick highlight here. My colleagues in the nicotine research group at King's College London recently published this year's Nicotine Vaping in England Evidence Review, which they were commissioned to undertake by Public Health England, which is now called the Office for Health Improvement and Disparities. They've published reviews since 2015, and this update is the most comprehensive to date. Its main focus is a systematic review of the evidence on the health risks of nicotine vaping. It also includes recent vaping prevalence data for young people and adults, and looks at flavors, nicotine, and people's perceptions of vaping harm. The next few slides feature prevalence data from this report. So here are some quick smoking and vaping prevalence statistics from England. So this is for adults in England. So smoking prevalence among adults in England was 13.2% in 2022, compared with around 12.7% in 2021 and 13.8% in 2020. This is the dark blue line. And the light blue line shows vaping. So vaping prevalence among adults in England was 8.3% in 2022, compared with 7.1% in 2021 and 6.3% in 2020. So vaping prevalence among adults who have never smoked is very low. It was at between 0.6 and 0.7% in 2021. And this is for young people in England, aged 11 to 18-year-olds. So smoking prevalence is the blue line. So this includes occasional and regular smoking, so it's quite broad, was 6% in 2022, compared with 4.1% in 2021 and 6.7% in 2020. And vaping prevalence, again, includes occasional and regular vaping, was 8.6% in 2022, compared with 4% in 2021 and 4.8% in 2020. Most young people who have never smoked are also not currently vaping, but the use of disposable vaping products has increased substantially, with 52.8% of current vapers using them in 2022, compared with only 7.8% in 2021 and 5.3% in 2020. And my colleagues always want to highlight that the data for 2021 almost seems like it's out of trend, but this is because it was collected during a COVID lockdown. So now I will talk about the studies I'm conducting as a part of my PhD. So as I mentioned, England will miss the smoke-free 2030 target by at least 7 years. And one of the challenges is inequalities, as smoking prevalence is considerably higher in disadvantaged groups. Increased cessation support and harm reduction approaches have been recommended to reduce inequalities in smoking prevalence. So my PhD overall investigates how smoking cessation treatment provision in the UK could be improved, and tries to explore this idea of how e-cigarettes and prescription e-cigarettes may help to further reduce the prevalence of smoking and meet the smoke-free target, including reducing the prevalence of smoking in disadvantaged groups. So I have 4 studies, and I'll try to go through them in turn, focusing on the first 2, because I don't have results for the last 2 yet. And please do consider these results preliminary, because none of them are published yet. So my first study was a systematic review. So the systematic review was entitled Implementation Strategies to Increase Smoking Cessation Treatment Provision in Primary Care, a systematic review of the observational studies. So the background to this was that most adults who smoke want to quit smoking, but only a minority make quit attempts, and these have a low success rate, and fewer than a third use evidence-based treatment. So despite the existence of evidence-based guidelines and recommendations, internationally, there's an evidence practice gap in the rates at which healthcare professionals assess tobacco use and offer support in clinical practice in the real world. So in this review, I used a concept from the field of implementation science called implementation strategies. So implementation strategies are methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program or practice. They have been suggested to help facilitate the movement of evidence-based practices into clinical practice in the real world. So to recap, what is evidence-based practice? So I think Shane mentioned the audience is full of clinicians, so hopefully you'll be familiar with this. So clinical guidelines recommend that health professionals address patients' tobacco use by giving brief advice. The first model for this was the 5 A's. And in some countries now, like the UK, the 3 A's or very brief advice, VBA, is recommended. So the evidence-based practice under consideration here is the 5 A's or VBA. And the implementation strategies are things which we do to increase the quantity and quality of the evidence-based practice, the 5 A's or the VBA. So to define implementation strategy, I use the constructs developed by the expert recommendations for implementing change ERIC program. They define 73 distinct implementation strategies and group them into 9 domains. So to make it a bit less abstract, one example of an implementation strategy I found in my review was the introduction of the Quality and Outcomes Framework in the UK. This was a financial incentive program aimed at encouraging general practitioners to carry out certain clinical behaviors, such as recording patients' smoking status. So according to the ERIC constructs, this policy would be classified as implementation strategy category 60, alter incentive or allowance structures, under domain 8, which is utilize financial strategies. So in this review, I tried to establish what implementation strategies have been enacted on a national or statewide scale, which were effective, which were cost effective, and what explanations have been proposed by the researchers carrying out the evaluations to explain why certain strategies were or were not effective. So I'll go through my methods. So for the systematic review methodology, you come up with search concepts and you try to search lots of databases which contain journal articles and grey literature, which can contain things like policy documents. So the key search concepts were smoking, smoking cessation, and primary care. And I followed the keywords and synonyms that Cochrane reviews have used in the past. And I searched several academic and grey literature sources, and then forward and backward citation tracking was conducted. So my main PICO inclusion criteria were here. So the target of the intervention was any type of healthcare professional within the primary care setting. Primary care setting was defined as family medicine or general medical practice, but it excluded public health interventions delivered outside primary care practices and interventions delivered in dental settings or pharmacies. And the reason for this was I followed this definition from a recent relevant Cochrane review. The articles were included if they evaluated an implementation strategy which aimed to increase smoking cessation treatment provision in primary care, which was implemented on a national or statewide scale. The control could be usual care, any other intervention, or before and after designs. Articles that assessed any of the primary outcome measures were included in the review. So the primary outcome measures were identification of the implementation strategy and effectiveness. So the effectiveness was either on the practitioner performance in the 5 A's or VBA level, or on the patient level, which included things like quit attempts and cessation. And then as secondary outcomes, to try to identify potential facilitators and barriers to implementation, we extracted these proposed facilitators and barriers from the studies which are included due to the primary outcomes. And we looked for any cost effectiveness measures as well. So the database search strategy yielded over 12,000 records, and then we screened them at title and abstract level, and then full text level. And for the risk of bias assessment, we used this tool called Robin's Eye, which is risk of bias in non-randomized studies of interventions. The tool helps to decide an overall risk of bias for each study, which could be low, moderate, serious, or critical risk of bias. And then due to heterogeneity in study populations and outcome measures in the included studies, a narrative synthesis was used. So based on the descriptions provided in the included studies, the key aspects of the interventions were coded to the 9 implementation strategy domains and the 73 categories developed by the ERIC program. The effectiveness on practitioner and patient level outcome measures was assessed. And lastly, the perceived facilitators and barriers which were extracted from the studies, and to help organize them, were mapped to the determinants in a framework called the Consolidated Framework for Implementation Research. So the results. So we ended up including 49 studies in the systematic review. Most of them were set in the UK and USA. One study had critical risk of bias, and therefore we decided not to include it in the rest of the results. 24 studies had serious risk of bias, predominantly due to receiving a poor rating for the bias due to confounding domain. 20 studies had moderate risk of bias. These had more sophisticated study designs, but didn't have pre-registered analysis plans. And 4 studies were at low risk of bias, and these were well-designed cohort studies. So overall, the risk of bias was high. So what implementation strategies were enacted on a national or statewide scale? So interventions in 6 studies used multiple implementation strategy categories, while the interventions in the other studies used only one key implementation strategy category only. So the 49 included studies assessed only 4 out of 9 implementation strategy domains. As you can see in this table, most of the implementation strategies that were involved were in the green and yellow domains, which were utilize financial strategies and changing infrastructure. So the 4 domains that we found were utilize financial strategies, change infrastructure, train and educate stakeholders, and engage consumers. So 34 studies evaluated interventions using an implementation strategy that increased funding towards the provision of smoking cessation treatment in primary care. 14 evaluated strategies that involved infrastructure change, which aimed to increase the provision of smoking cessation treatment in primary care. 3 studies evaluated strategies that involved training and educating health professionals in primary care who deliver smoking cessation treatment. And 3 studies evaluated strategies that involved engaging people who smoke to raise awareness about the availability of cessation treatment in primary care. So in the manuscript, I discuss the domains broken up into the categories, but for the overall kind of summary and this slide, these are the top line effectiveness findings, where it's just by domain. So overall, the majority of studies identified didn't measure patient level outcomes. We found some evidence for interventions which utilize financial strategies having a beneficial impact on cessation. So there were 34 studies which investigated interventions utilizing financial strategies, but only 4 were at low risk of bias. These studies appeared to increase the recording of smoking status and cessation advice, but the effect on cessation medication prescribing was mixed. Only 1 study assessed quit attempts, and it found no effect. And 7 out of 9 studies which assessed smoking cessation found an increase. Then there were 14 studies which investigated interventions changing infrastructure, and none of these were at low risk of bias. So these had mixed results for smoking status recording, cessation advice provision, and cessation medication prescribing. No study measured quit attempts, and only 1 out of 3 studies which assessed smoking cessation found an increase. Only 3 studies, all at serious risk of bias, investigated interventions which trained and educated stakeholders. These indicated a beneficial impact on smoking status and cessation advice recording and smoking cessation, but these should be interpreted with caution because the evidence was low quality. And lastly, there were 3 studies which investigated interventions engaging consumers, and none of them were at low risk of bias. So 2 studies here showed no effect on cessation medication prescribing in primary care. 1 study assessed cessation advice provision and smoking cessation, both increased, but the intervention here also involved implementation strategy categories, which involved the above domain, so training and educating stakeholders. And the effectiveness was attributed to this training and educating stakeholders domain by the study authors. And no studies assessed cost effectiveness. And here are the qualitative outcomes. So from these 49 studies, we extracted the researchers' opinions about what they thought kind of reasons that can contribute to effectiveness or non-effectiveness. So some of the key facilitators were that the intervention should be simple, accessible, and adaptable, and complementary policies and incentives, such as tobacco control measures, anti-smoking social norms, and funding for public health and cessation clinics can help. And systems-level interventions, which allow easy referral to cessation programs or community-based support from primary care, were recommended. And some of the key barriers were time and resource constraints in the clinic, lack of access to free cessation medications and follow-up appointments, incompatibility with and lower priority of the 5 A's or very brief advice compared to existing clinical demands, and the wording and coding of incentivized targets not optimally targeting the desired clinical behaviors. For example, like financial targets focusing on the risk factor identification and not the intervention aspect of cessation treatment. And for healthcare professionals, some studies suggested lack of knowledge and training around guideline changes, physicians having doubts about the effectiveness and safety of cessation interventions, and physicians not feeling competent to deliver cessation counseling. And for people who smoke, lack of awareness of and negative perceptions about the effectiveness of cessation medications. So to conclude, the studies we included in our review were observational studies. These can provide evidence of real-world implementation, but they are at risk of bias and unable to demonstrate causality. The majority of studies identified in this review did not measure patient-level outcomes, but we found some evidence for interventions which utilize financial strategies having a beneficial impact on cessation. For future research, they could investigate the 5 implementation strategy domains not identified by this review, and strategies that were efficacious in the controlled trial setting, such as adjunctive counseling and tailored print materials. And we advise that hybrid effectiveness implementation designs are used. So these would be studies where they robustly assess both the effectiveness of implementation strategies on provider level or practitioner level outcomes, as well as patient level quit attempts and smoking cessation outcomes. Additionally, we recommend measuring advice provision about e-cigarettes in the future, as now some clinical guidelines recommend it as harm reduction tools. And lastly, we recommend using methods such as multi-phase optimization strategy, which consider the time and resource constraints of clinical settings, just to make sure that you can verify that all components of the 5 A's of very brief advice or the proposed implementation strategy interventions are optimized and cost effective. Okay, on to my second study. So the background for this study was that we know that smoking prevalence is higher in people who have mental health conditions. So for this study, I wanted to investigate whether there were any differences between people who smoke and have depression or anxiety compared to people who smoke but don't have depression or anxiety, in terms of, in the last 18 months of them taking the survey, the odds of them visiting a health professional, the odds of them receiving advice to quit smoking from their health professional, the odds of them receiving specifically a positive recommendation to use a vaping product from their health professional, and lastly, the odds of them using various cessation aids or vaping products in their last or currently ongoing quit attempt. So for this study, I analyzed some cross-sectional survey data collected in 2018 from people who smoked and vaped in Australia, Canada, England, and the US. This is using data from the International Tobacco Control ITC Policy Evaluation Project. So after calculating some weighted proportions, I generated weighted logistic regression models for each outcome measure. I had an unadjusted model which just had mental health as the independent variable against the outcome. Then in my first adjusted model, I controlled for country, sex, age, highest level of education, ethnicity, and annual household income. Then in my second adjusted model, I controlled for these variables plus 2 additional ones, so cigarette smoking status and problematic alcohol use. And to assess whether the association between mental health and each outcome varies by country or not, I added in an interaction term between mental health and country alongside the above mentioned variables. So this was my adjusted model 3. And to make my analyses more robust, I used Born-Ferroni correction so that the only results which were considered statistically significant were those where the p-value was below 0.007. And here are the results. Yeah, busy slide. Right. So these are just the results from adjusted model 2. So for the first outcome, most, so that's nearly 75% of respondents reported visiting a health professional in the last 18 months. The odds were higher for those respondents who had a mental health condition. And for the second outcome, less than half of respondents who visited a health professional reported receiving advice to quit smoking. So this was overall for all respondents. And with those respondents having depression alone, having higher odds of reporting being given advice to quit smoking from a health professional compared to respondents who had no mental health condition. And for the third outcome, where discussion with health professionals included vaping products, only 1/3 of respondents reported receiving a positive recommendation from their doctor to use them. And the odds didn't differ between mental health status, but our sample size was small for this outcome. And among those who either made a quit attempt or had recently quit smoking in the last 18 months, for outcome 4A, so these people who had ever tried an e-cigarette, 43% of respondents used a vaping product in their last or current quit attempt. And the odds of using a vaping product to quit smoking didn't differ between mental health status. And then moving on to the other cessation aids. So less than 1/3 of respondents had used NRT in their last or current quit attempt. And the odds of using NRT were significantly higher for respondents with both depression and anxiety compared to respondents with no mental health condition. And the proportion who used varenicline or bupropion in their last or current quit attempt was low for all respondents. So it was only 12% of people used these cessation medications. And we didn't find a significant association between mental health status. So our sample size was borderline here. And for the last outcome, the proportion who used behavioral support in their last or current quit attempt was also low. This was 11%. The odds were significantly higher for respondents with depression alone and those who had both depression and anxiety compared to respondents with no mental health condition. But our sample size was low for this outcome. And then for our brief exploration into country differences. So we attempted to explore interaction effects between mental health and country, and we found that there may be a significant interaction regarding visiting a health professional, but we didn't have high enough sample size to investigate this further. So we do recommend investigating this in the future by stratification if your sample size is higher, and we didn't really find significant effects for the other outcomes. So the results of this study are preliminary and the discussion is at an early stage, but here are some of our preliminary ideas. People who smoke with mental health conditions had a higher odds of visiting a health professional, but we're not sure if they received cessation advice at the same rate as people without mental health conditions. And secondly, it was concerning that overall less than half of all respondents reported receiving advice to quit smoking. We advise that health professionals increase the rate that they provide cessation advice and support to all of their patients who smoke. And for vaping, we found no association with mental health status and being given positive recommendation by your doctor to use vaping products, or the odds of people using a vaping product in a quit attempt. So although all people who smoke should be given access to vaping products, because smoking as a smoking cessation option, given that nicotine-containing e-cigarettes are efficacious as a smoking cessation aid, and that people with mental health conditions are more likely to smoke heavily and be highly dependent on cigarettes. We think it is especially important for this subgroup of people to be given accurate information about and access to e-cigarettes. And for the other cessation aids, so overall, the proportion of people using NRT, varenicline or bupropion, or behavioral support in a quit attempt was quite low. However, it's promising that the rate of respondents with mental health conditions using NRT and behavioral support appeared to be higher than those without mental health conditions, because past research has shown that people with certain mental health conditions are motivated to quit smoking and are more likely to make quit attempts, but are less likely to succeed. But overall, it is important that everyone who smokes has access to these aids, because quit attempts are more likely to be successful with cessation aid use. Okay, and then very briefly, I will outline the last two studies of my PhD. So they use electronic health records from primary care in the UK. So I've got two studies planned, and the UK primary care system has been fully computerized since the late 1990s. So we've got quite a good data set to use for research. The data I'm using is from a data set called Clinical Practice Research Data Link, or CPRD, which is nationally representative of the UK. So for my first study, I want to investigate if and how e-cigarette use is being recorded by GPs in the UK. So there are med codes to do with e-cigarette use, which doctors can add digitally to patient appointment files. So the main objectives are to track the trend through time. So e-cigarettes came into the UK in around 2012 and see if any patient characteristics are associated with having an e-cigarette use med code, and ultimately see if the data can be used to estimate annual e-cigarette use prevalence. And for the second study, I want to investigate if and how the addition and removal of the black triangle safety warning that was added onto varenicline had any effect on its prescription rate by GPs in the UK, and tried to explore if this effect differed by mental health status and socioeconomic status. Okay, that's the end. So thank you for listening. So to recap, I outlined the smoking and vaping context in the UK, giving some information about recent policy developments and the clinical guidelines that we have around e-cigarettes. And then I briefly spoke about my PhD studies. Here are some references, and there are references within the slides as well. So if you need access to anything, feel free to email me. Thank you for listening, and I want to thank my supervisors and my other collaborators and colleagues who make my work a lot better. And my PhD funding is from the ESRC LIST DTP scheme. Okay, thank you.
Right, thank you, Bernadette. I'll get you to press the stop sharing slides, and we'll bring up. It's a real pleasure to see the next generation of researchers coming through. And speaking of young people, we've got Professor Hayden McRobbie on the line here, and Hayden, that's a very interesting body of work, and I know it's right up your alley as a clinician and researcher. Do you have any what things stood out to you from that presentation?
Thanks, Shane, and Bernadette, lovely presentation. Shane, I thought you were going to introduce me as another young person on this, so I guess the grey hair doesn't quite allow for that. Look, I think there are a few things that stood out, and if I may just start off by sort of just giving a little bit of an overview that, you know, the UK has been I think fair to say, or England is fair to say, has led the world in a number of tobacco control activities, but particularly in smoking cessation services. And so it was back in 1999, of course, that funding started to trickle through for dedicated face-to-face stop smoking services. And these really grew over the early 2000s. So some world-leading research that came out of that. And I think also that the UK was an early adopter of electronic cigarettes or vaping devices for smoking cessation as well. In the face of a lot of nervousness, I think it's fair to say, from around the world. And now you see, of course, in these nice guidelines, active recommendation for these vaping products for smoking cessation. Look, I think the most recent Cochrane review supports that decision, and the evidence is strengthened, although there are still relatively few clinical trials on e-cigarettes compared to other smoking cessation aids. The evidence has indeed strengthened over the last few years that I've been involved in the Cochrane review. I guess compared to Australia, and it's not to say that Australia hasn't been a world leader in tobacco control, because Australia has, and has had some of the best tobacco control measures of any country around the world. But perhaps it's had slightly less emphasis on the smoking cessation element of the tobacco control continuum, if you like. Although having said that, I mean, Australia's got some really good quitline and other electronic quitting tools, I suppose. What Australia doesn't have is easy access to vaping products anymore. So as you all know, you are able to get nicotine-containing vaping products, but you need a doctor's prescription to do that. So in the light of the evidence coming from the UK suggesting that actually vaping is making a difference, although you didn't present all those data, Bernadette, I acknowledge, but you've got bodies like NICE saying, yeah, let's put these into services, and services should be recommending these. And then you've got New Zealand, somewhere I think in between all of this. I mean, we've followed the lead a little bit in the stop smoking services from the UK. We do allow access to vaping products with some restrictions. New Zealand was much further behind the UK in implementing some of the regulatory environment that you've had. And the UK, it's been since 2014 with the EU Tobacco Products Directive. Excuse me if I got that date a little bit wrong, but we've only more recently had restrictions on sales put in place. And I do wonder whether that's a contributing factor to the uptick we've seen in young people who have never smoked starting to vape, which is higher than what you've seen in the UK. With all of that, though, our daily smoking rates in New Zealand in 2022 are down to 8%. So that's a bit of a win for us. And our daily vaping rate for adults is exactly the same as the UK, 8.3% in 2022. So it's difficult to say that actually. It's difficult to say whether vaping in New Zealand has contributed or how much it's contributed to the reduction in smoking prevalence. Given that daily vaping is 8.3%, and in some populations such as Māori women, it's 21.2% of that population smoking on a daily basis. Having said that, Māori women have had the highest smoking rates of any group in Aotearoa, New Zealand. And if I look back at the daily smoking prevalence for Māori women in 2015-16, it was 36.6%. 2022, it's halved. It's down to 18.2%. So there's some gains that have been made across all of this. And the last point I want to make is it's great to see the comments there and the research you're doing on brief interventions for smoking cessation in hospital settings. I do look back on what we've done in New Zealand probably over the last 10 to 12 years now, where we had a very strong focus of implementing brief interventions in primary and secondary care. And there was a lot of focus, a lot of emphasis. There were government targets reporting the number of people who smoke, a proportion of people who smoke that had a brief intervention, with a target of 90% in primary care. I'm not quite sure how much difference it made because we didn't measure those other outcomes and we rely on these other survey tools to do that. I guess the question for me is how much effort does one continue to invest in this when maybe there are some other interventions now that we should focus on? And my feeling is we've probably done it enough now, and I would hope that within the system there's enough there to keep it going. That's probably not true, and you will probably need some top-ups as we go through. But your research suggesting some other things there too with payments or incentives, and I think that's something that is not always easy for a health system to accept, that actually paying people to stop smoking may be one of the best interventions that we've got, but there's some aversity to using health money in paying people to change their unhealthy behaviors, often with the perception that was their own fault to start with. Anyway, I'll finish rambling there, but nice presentation.
Thank you, Hayden. Actually, I'll get on to questions, but that payment issue, of course, contingency management is, there's a lot of interest in the area of illicit substances too, basically, for instance, rewarding people for having clean urines, etc. But you run into exactly the same issue. But I suspect what you would say, the amount of money saved is going to be infinitely greater than the amount of money spent. It seems to me. But I'll send this first question to you. It's Bernadett. Katrina, I'm not familiar with the study. Said a recent NHMRC report found that use of e-cigarettes was correlated with dual usage, which I assume means smoking as well. In your data, was there any evidence of people were using both routes of administration?
In which study?
In the UK data. Sorry, the national data. You've got people who vape and people who smoke. Are there a proportion that do both or move from one to the other?
Oh, I don't know. Yeah, I feel like this was my blunder. So I didn't work on the nicotine evidence review.
No, that's okay. I mean, it's an old issue. Yeah. It's not an old issue, sorry. It's an issue that, and I'll get your views, Hayden, from a clinical perspective. Is there any evidence that people that are vaping are necessarily going to move on to smoking as a transition?
So vaping to smoking.
Yeah.
Yeah. So you're talking about gateway
Correct. I think that's
effect
that's the aim. Yeah.
in there. You know, the gateway effect's always really difficult to prove or disprove categorically. But I think it's fair to suggest that the data that we do have, if there is a gateway effect for vaping to smoking, it would be a very small effect overall.
Yeah, yeah. I'm always, to be honest, the gateway always seems very hard to get through for most things. I see it in the illicits as well. I suspect it's also one thing that we'll only be able to comment on in 20 years' time when there's been sufficient generations gone by. There's a question from Jackie. I'll put it to you, Bernadett, the first part of it anyway. You talked about disposable vapes in the UK. It was just speculating. Jackie's wondering, would that be a reason by youth experimentation because they're cheaper?
Yeah, I think that's what my colleagues have mentioned. Yeah.
Right. And the second part of that, would that therefore be a more cost-effective intervention? Yeah. I mean, could that be a cheaper way to provide an intervention that people are going to maintain it on?
As in, are you saying, do disposable vapes have a potential to help people quit? Yeah, I think they do. Yeah, I think, to me, it seems like with all these issues around, and even like flavors and, you know, the way these vapes look, is that they're attractive to both adults and children. So yeah, I think disposable vapes have been shown to help people quit smoking, because some people do find them easier to use.
Yes, Ryan Courtney has just asked a question about flavours here, and should we restrict flavours? I mean, do either of you have any views on that? Bernadett?
I think generally it's a very contentious issue. I don't think you should restrict flavours because, as I said, I think adult smokers like them. So if it's going to help these people stop smoking combustible cigarettes,
yeah,
then restricting them is just taking away a cessation aid from them.
Hayden, Ryan's asked a very long question, Ryan, with 70 parts. I'll ask the first 80. He says, but it's an important question, and Hayden, and you'd be aware of this research. He's saying most of the trials have been done with dosages under 20 mg per mil, 20 milligrams per mil, and poor nicotine delivery is seen as a problem. I mean, do you have any feeling as to what sort of dosages we should be considering in smoking cessation for e-cigarettes?
It's a good question, and I guess the perfect dose is enough for helping people to quit smoking and not enough to addict non-smokers very quickly. I mean, and that's a very theoretical answer, of course. I guess the other thing to remember is that the strength of the nicotine in the solution is just one factor that's related to the amount of nicotine that you absorb into your blood, and that has that biological effect. So you can have devices that operate on higher power that you can use a lower concentration of nicotine in and still get relatively good blood nicotine levels. Some of the lower power, and especially some of these smaller pod devices, benefit from a higher concentration of nicotine in the liquid to be able to deliver those amounts. So it's a little bit of it's not an easy question to answer. It's not like taking a tablet or a medicine where you're going to get a standard dose. It's been tried and tested, because how you puff on the vaping device, some of the constituents even within the e-liquid also might affect nicotine delivery. I just want to make one other point about disposables. Two other points, one about flavors, one about disposables. Disposables could potentially become more of a problem too, and in the environmental impacts of it. If you think about some of these devices, cheap, you're disposing of them, they have batteries, of course, in that. So not particularly environmentally friendly. I think some of those disposables could be made better, whereby, you know, even if you had a replaceable battery and those things, I guess that means they would no longer be disposable. But you know, just something to consider. And in terms of flavors, I agree with Bernadette. I think a variety of flavors is important for people who are vaping. What I think could be restricted, though, is the descriptors of those flavorings, where you've got, and this has been a common theme throughout, where some of the advertising, you know, describes these flavors as, one I Googled yesterday because someone asked me and I didn't quite believe that there was a flavor in New Zealand called unicorn milk, but there is indeed a flavor called unicorn milk, which is a mix of custard, vanilla, and something else. So, you know, there's no need to do that. We could just list the flavors on the packet, you know, what it tastes like, great, but we don't, I think those are the sort of things that we could restrict more.
So I'll get on to mental health in a second, but there's a question that I'll ask to you, Bernadette, because it's something that's always interested me. So an attendee is asking, should the overall goal of smoking cessation be nicotine cessation, which of course we've moved, again, this is a route of administration, they're arguing is abstinence to and I suppose linked into that, is there a role for maintenance? You know, in the same role as say buprenorphine or methadone in opioid dependence. Do you have any views, Bernadette?
I really dislike questions like this because my past as an academic was not in the addictions field, but so I don't know. I think personally, so people have a lot of opinions about addiction and drugs.
Trust me, I know that.
Yeah. And it's sometimes inconsistent. So for example, caffeine is, you know, freely available. There's both kind of pros and cons in terms of the health effects they can have long term. Usually they say that there's no major long-term health harm. But people, I guess, are still addicted to caffeine. So I think if nicotine can get to that level, then morally, I think it'll be acceptable. But then on the other hand, you've got this issue around if a person is addicted to a substance, then like, especially if they come from, you know, low socioeconomic background, they end up spending a lot of their income on these drugs, which decreases their quality of life in that way.
Yeah. Well, I mean, it's an interesting question because I mean, but Renee Batoon, I'll send this to you, Hayden. So let's assume we're you know, we've got a high risk group, people with, for instance, psychotic illness, high risk smoking group. Is nicotine, does it have any, she's basically asking, is it benign in regard to mental health, or do we put that in the context of greater harm?
Yeah, I don't think we can say anything's benign.
No.
And, you know, nicotine, you know, has impacts on your neurotransmitters. If you're talking about young people, there's possibility of you know, that changing some of the neural development. So I think it's I think when we're talking about nicotine in this regard for people who smoke, it's the less harmful part of a behavior here. And it probably relates to someone else's question I just saw about, you know, is the goal to be nicotine free as well? And, you know, I think ideally, yes, that would be the ultimate goal. The key thing is that balance between, you know, getting people off the most harmful nicotine delivery system, which is smoked tobacco still, and onto something much less harmful. We know that people use nicotine replacement therapy long term as well. So, you know, some people are using nicotine chewing gum for quite some time. The evidence around long-term use of nicotine suggests that it's associated with pretty few, some would argue if at all, any serious long-term consequences. We can't say the same about vaping. And of course, the aerosol contains a number of other things, and we just don't know yet what the harms associated with long-term vaping would be.
I mean, it's interesting, Bernadette. This is an area that is recent, relatively recent. And as I said earlier, 20 years down the track, we can answer those questions probably. But it is interesting, but there are needless, in the absence of this evidence, there are, however, very strongly held opinions. I think it's a fascinating area, but it does remind me, I look back at the fights, the controversies over methadone in the 1980s, which are largely forgotten now. But it strikes me there are analogies here in terms of changing of a route of administration, not towards, in that case, you're not having the person move in the immediate term beyond opioid dependence, but their health improves, their mental health improves. It seems to me that this is this type of role, the change of route of administration is what both of you are emphasising here. Yeah, by the way, someone else is agreeing with you, Hayden. I agree. I agree with you all the time, but said the disposable vapes contain batteries, so they're cheaper, they're bad for the environment. So, I'll just finish up here and we'll just wrap up. Bronwyn Williams, it says, and I'll send this to you, Bernadette. Perhaps Nicorette inhalers should be government subsidised for people. I mean, we can't make government policy, but would that be the sort of thing that would be consistent with UK policy at the moment?
I think, are these inhalators, which aren't e-cigarette? I think you can already get them. I don't know if you can get them on the NHS, but I thought they didn't really take off because they weren't as effective as e-cigarettes in delivering the nicotine.
Okay. Yeah, I'm not sure what the situation is here in Australia. It's much more restrictive. But I suppose the issue there is it's saying, would it be effective? Is it good government policy, or would it be health policy to subsidise the change in route of administration? I think that's what they're getting at. We could never answer these, and it has been a real pleasure, Bernadette, to hear about your research. It's an incredibly important area, and I think we shouldn't forget the successes. When I was a boy in the 1960s, it was about 60–70% smoked. So, as Hayden said, we have to look at our successes. But thank you, Bernadette. It's been a real pleasure. Hayden, always a pleasure, and to have your wisdom on board and your clinical expertise. It's been a really great session, and the audience questions have indicated a real engagement with it. So that is our last webinar for 2022, and you can view all of them on our website. Now, after 25 years of hosting the NDARC seminars and webinars, this is my last session in that role. It's been a privilege to present untold hundreds of speakers across the years, excellent speakers, including our panel today, and to work with so many brilliant colleagues. But fear not, I leave you in safe hands, and we look forward to seeing you in the ballroom in February 2023. So have a wonderful Christmas and New Year, and to one and all, live long and prosper.